The good news is that most children with an MTBI have a good recovery and no longer experience symptoms within a couple of weeks. The speed of their recovery, however, may depend on appropriate management of their injury. There are several things to review prior to discharge of a patient with MTBI. Providing both written and verbal instructions is preferred. Prior to discharging a patient from your care, you should counsel patients and their parents about warning signs indicating more serious injury. This includes a check for signs of deteriorating neurological function. Tell parents what to expect, what to watch for, and which signs require immediate medical attention. Talk about the expected recovery if management recommendations are followed, and inform parents that some symptoms may not be noticed until a few days after the initial injury. Discuss prevention of further head or brain injury throughout the course of recovery. This may include refraining from activities with a high risk of falling or activities imparting substantial force. The patient should not participate in prolonged submersion activities. Review management of cognitive and physical activity and rest. This includes a short rest period of 2 to 3 days and then a gradual return to non-sports activity. We will provide more details on returning to activity later in the course. Provide instructions regarding return to school and return to sports or recreation. A patient should not leave an emergency department or other healthcare setting and return to sports the same day. A firm date should not be given for a return to sports at the time of an emergency department visit. Provide clear instructions for patients to follow up with their primary care provider. By providing verbal and written education, reassurance about the likelihood of recovery, and helping your patients to understand the importance of post-injury care and behavior modification, your patients will be better positioned to have positive health outcomes. Healthcare providers should customize a child's return to activity based on their specific symptoms and level of severity. Counsel patients that new concussion symptoms may appear or reappear during the normal healing process and will generally improve over time. For the majority of patients, their return to activity should first include a brief period of rest, about 2 to 3 days, from physical and cognitive activities. Too much rest beyond this period may worsen a child's symptoms and prolong recovery. Patients should get a good night's sleep and take naps during the day as needed. They should engage in relaxing activities at home and avoid activities that put them at risk for another injury to the head and brain throughout the course of recovery. Within a few days, the patient can begin non-strenuous activities that do not exacerbate symptoms. This may include brisk walking for 15 to 20 minutes each day. During this time, parents should closely monitor their child's symptoms and any changes in severity and report back to you any concerns. Within a few days, patients can return to school as tolerated. It is important to ensure that there is communication with the school regarding any supports the patient may need. Examples include breaks and adjustments to the workload to minimize worsening of symptoms while at school. Good communication with the school is essential to help make the school transition easier for the child. Next, when symptoms are mild and nearly gone, a patient can return to most regular non-sports activities. At this point, patients should return to a regular school schedule. Patients should not start a return to sports activity protocol until they are back to their regular routine, such as school. When the patient is able to do all of their regular activities without experiencing any symptoms from the injury, the return to activity process is complete. During recovery, be sure to counsel patients regarding over-the-counter or prescription medications that are safe to take to help with symptoms, such as ibuprofen or acetaminophen for headache. And remind patients or their parents to limit the number of soft drinks or caffeinated items to help ensure the patient gets enough rest. Not everyone will recover quickly. Some will have persistent symptoms that last for months or even longer. Healthcare providers should monitor children with MTBI who are determined to be at high risk for persistent symptoms based on premorbid history, demographics, and/or injury characteristics. For children with MTBI, whose symptoms do not resolve as expected with standard care within 4 to 6 weeks, healthcare providers should provide or refer for appropriate assessments and/or interventions. Painful headache is one of the most common symptoms in children and may require intervention. Healthcare providers should offer non-opioid analgesics to children with painful headaches following acute MTBI, but also provide counseling to the family regarding the risks of analgesic overuse, including rebound headache. Chronic headache following MTBI is likely to be multifactorial, and therefore, healthcare providers should refer children with chronic headache for multidisciplinary evaluation. Dizziness is another debilitating symptom. Limited evidence suggests early vestibular physical therapy may benefit patients reporting or experiencing this symptom. Healthcare providers may refer children with subjective or objective evidence of persistent vestibulo-ocular motor dysfunction following MTBI to a program for vestibular rehabilitation. Sleep disturbances are common and may lead to ongoing problems. Adequate sleep has been shown to improve overall health and should be an important part of treatment for children with MTBI. Healthcare providers should provide guidance on proper sleep hygiene methods to facilitate recovery. If sleep problems emerge or continue despite appropriate sleep hygiene measures, healthcare providers may refer children with MTBI to a sleep disorder specialist for further assessment. You can access sleep hygiene tips for patients with MTBI in the Resource Center. Problems with attention, memory and learning, response speed, and other cognitive impairment can occur following MTBI. These disturbances can result in significant problems with learning in school or social interactions. Healthcare providers should attempt to determine the etiology of cognitive dysfunction within the context of other MTBI symptoms and recommend treatment that reflects its presumed etiology. Healthcare providers may refer children with persisting complaints related to cognitive function for a formal neuropsychological evaluation to assist in determining etiology and recommending targeted treatment. For most patients, returning to school can begin within a few days after the injury. Ideally, a child's return to school will include collaboration among healthcare teams, school, and families. Their return to school plan should be customized to their individual symptoms and carefully planned to gradually adjust to support return to participation in school activities without worsening symptoms. When returning to school, students should be monitored for the following signs: increased problems concentrating and remembering new information, longer time required to complete tasks, increased symptoms such as headache, fatigue, and irritability when working, poor academic performance. A patient's return to school plan may include these supports: time off from school, shortened day, shortened classes, such as rest breaks during classes, rest breaks during the day, allowances for extended time to complete coursework, reduced workload, untimed tests, no significant classroom or standardized testing until symptoms subside. Tolerance for cognitive activity increases as the student recovers, but the rate may vary from one student to another. Symptoms and academic progress in school should be monitored collaboratively by the student, parents, healthcare provider, and school teams to jointly determine if modifications or accommodations are needed to maintain an academic workload without significantly exacerbating symptoms. Students who demonstrate persistent symptoms and academic difficulties despite an active treatment approach over a period of 4 to 6 weeks should be referred by their healthcare provider for a formal evaluation by a specialist in pediatric MTBI. School-based teams should also assess the educational needs of that student and determine the student's need for additional educational supports, including those described under pertinent federal statutes. For children who have not had symptom improvement, despite active treatment for 6 weeks, you may also recommend a Section 504 plan. Section 504 plans are implemented when students have a disability, temporary or permanent, that affects their academic performance. Services and accommodations for students may include environmental, curriculum, methodological, organizational, behavioral, and presentation strategies. Check out the Resource Center to download tools to help communicate with schools and help with return-to-school planning. As with diagnosis, there are specific considerations related to returning to sports following an MTBI. Children are often anxious to get back to sports and recreation activities, but returning to sports is not a child's, parents', or a coach's decision. It's yours, and the return to sports process should only begin once the patient is back to their regular activities, such as school. Return to sports, also referred to as return to play, is an individualized process that should consider pre-existing conditions, severity of the injury, and age. The younger the athlete, the more conservative the approach. Based on the International Concussion Consensus Guideline, there are gradual steps to safely return an athlete to play. The return to play progression is best conducted through a team approach and by a health professional who has worked with the athlete and knows the athlete's physical abilities and endurance. The steps in the return to play progression include: Step 1. Back to regular activities. The return to play progression should only begin with your approval and once the athlete is back to their regular activities, such as school. Step 2. Light aerobic exercise. This may include walking or stationary cycling at slow to medium pace. At this time, there shouldn't be any resistance training, but it is okay to increase heart rate. Step 3. Sport-specific exercise. During this step, there can be an introduction of running or skating drills. However, there should not be any activities that involve head impacts. Step 4. Non-contact training drills. Here, the athlete can do more difficult training drills, such as passing drills. They can also start progressive resistance training and exercise that includes coordination and increased thinking. Step 5. Full contact practice. At this point, you should assess if the athlete is ready for normal training activities. During this process, the athlete can restore confidence and coaches can help assess functional skills. Step 6. Return to sports. Normal gameplay or sports activity can now happen, and the return to play progression is considered complete. If symptoms return, stop these activities. Only after additional rest, when the athlete has not experienced symptoms for a minimum of 24 hours, should you start again at the previous step. This means that if an athlete has symptoms at Step 4, after a period of rest without symptoms, the athlete should restart the progression at Step 3. During the return to play progression, be prepared for athletes to offer resistance, as they may feel frustrated, sad, or even angry about having to sit out. Communicate with parents about these potential reactions from athletes, and remind parents about the important role they play in an athlete's recovery. You and an athlete's parents can also help by checking in with the athlete on how they are feeling and acknowledging their feelings, being honest about the risks and explaining how taking these gradual steps will actually help them get back to play more quickly.